Hey folks, Weingart here. Now, if you like medical legal stuff, if you practice emergency medicine, if you care about the management of sick patients and how people are going to perceive it, then you're in for a treat. My friend Mike Weinstock of Bounce Back's fame, of numerous amazing books, I'm working with him on one right now. My friend Mike did a mock trial, a full mock trial. I mean, not a 2-week mock trial. He condensed it down to 2 hours. But what he did is he took a real case and then he got people to act as expert witnesses and as the actual defendant and gave them the latitude to look at the case and make their own vision of how they would represent in their assigned roles. And what you will find is that it is very fascinating watching or listening. So I love this. I think you will too. Here's the deal. You might be watching this on video on the EMCrit site or on YouTube. If instead you'd prefer to just listen to this in a car, the EMCrit feed has the audio version. I don't think you lose that much by listening rather than watching. So if you're like really dejected, you now have to sit in front of a screen when you want to go running, don't worry, just listen to it on the EMCrit feed. If on the other hand, you're listening on the EMCrit feed and you're like, wow, I'd really like to see the people involved and they did some really nice camera work filming this thing, then stop listening there and go on over to the EMCrit site and you will find the video. This, like I mentioned, is the interpretation of the people involved. They are not taking a verbatim script. They are working from the case and then making their own interpretation of how they would represent. I find this fascinating, especially for the plaintiff expert, because what they did is they managed to simulate something I've seen in court on both sides, on both tables, as both a expert witness and as a actual witness of the material matters in the case. I felt the same sense of frustration and near rage at the things that were being entered into the trial as fact that were just not true. So they managed to really duplicate how it's like in court, which is kind of amazing. Now, I'm not going to put the verdict here in this first take. What I want you to do is after you listen or watch, go to emcrit.org/mock trial. And in the comments, say guilty or innocent. And then a couple days from now, we'll put the verdict. And then further, we'll bring Mike onto the show to talk about some of this stuff. And then I realized, listening to this case, I have not done the EMCrit episode on anaphylaxis yet. So that will be done in the next few weeks. All right, enough crap. Let's get right to it. Mike Weinstock doing mock trial at Ohio State University.
I'd like to welcome everybody here to the beautiful Ohio State University campus. I'm so excited to have such a great group here, a multidisciplinary group. We have emergency medicine residents, we have PA students, we have family medicine residents, and we have other physicians and providers who are interested in this process of what happens at a trial, what happens when things don't go exactly how we'd want them to go with an encounter with the patient. Now, this mock trial will be a little bit different than if you've ever seen one in the past, because in addition to showing the process of how we go about finding a resolution, I should say, to a encounter with the patient, in addition to that, we're also going to try to teach some medicine too. So I'm going to talk more about this case. It's a 47-year-old woman who presented with anxiety and anaphylaxis. Anxiety and allergic reaction is how she was initially seen. But before we do that, I wanted to just introduce a few of the folks and talk about the format that we're going to be doing here, and also what's necessary to prove negligence in a medical malpractice trial. So there are 4 elements that we really need to show that will prove malpractice. The first is that the physician or the provider had a duty. That's usually pretty easy, right? We're wearing a white coat. They're wearing a thin hospital gown. Second is that there was a deviation from the standard of care. And the standard of care is, as we all know, a standard of care that is what a like or similarly trained provider would do in a like or similar situation, similar circumstance. That there was patient harm is number 3, and then the 4th is that there was some sort of causation, or that's the proximate cause. In other words, what we did or failed to do somehow caused that patient's injury. Now, it's always better, of course, to do things from a standards defense. It's always better to say, I did things the way that I should have done them, as opposed to saying something like, well, I screwed up, but the patient would have died anyway. That's not usually the best way to approach things when you go to a trial. The good news is that for trials, very few of these cases actually go. Less than 10% of allegations for medical malpractice will actually go to trial. Most of us, fortunately, will never see the inside of a courtroom except for the courtroom here at Ohio State. So welcome again to all of us here. Welcome to the national listeners who are watching in different emergency medicine and other residency programs around the country. And I am hopeful that we'll have some really good takeaway points, mostly for patient safety, mostly to improve the care that we give to patients at the bedside. We, in addition to that, have a 8-member jury. This is actually the only true jury of our actual peers, because these are emergency medicine physicians here. And they will vote, as well as all of us will have an opportunity to vote at the end if standards were met and if the bar of causation was met also. So I'm going to introduce the other participants in our trial here, and we're going to get right to it now. We're going to tell you about this case. I should have introduced myself. I'm Michael Weinstock. I am the Associate Program Director at the Emergency Medicine Residency at Adena, as well as Professor of Emergency Medicine Adjunct here at the Ohio State University Emergency Medicine Residency. This is Mike Palacci. He's the Program Director at Adena. He will be the defense expert witness. We have Colin Cade. He is the Associate Professor of Emergency Medicine here at Ohio State. He is the plaintiff expert witness. He is on the plaintiff table here. And we have our volunteer defendant. This is a third-year resident, Bob Cully, at Adena Emergency Medicine Residency. So thank you so much for doing this, volunteering to do this, right? Yeah. And, and then we have our 8-member jury of the peers. This is composed of both Ohio State and Adena emergency medicine physicians. So without further ado, if we could dim the lights briefly here, and I'm going to tell you about this case. As we said before, this is a true case. The times are actual as to what happened. This is a 47-year-old woman who went to her primary care physician office with 2 main complaints of sinus problems and of depression. She was prescribed Avalox and she was prescribed Zoloft, and she was sent home. Unfortunately, later that evening, she began to have some difficulties. She began to have some shortness of breath, some flushing, and they called the paramedics. They transported her to the emergency department, where she was placed in a room, and she was seen initially by a physician assistant who noticed that she was sick. This was an experienced physician assistant who'd been working for years, fantastic PA, who looked at the patient and said, "She's sick, we need to move her." They moved her immediately to one of the sort of major medical trauma rooms, and at that point, they started this documentation of the other bad events that were happening. So lightheadedness, throat tightness, red rash. The physician documented the same, as well as the fact that she had some shortness of breath, no chest pain, and it was, after she got transported, very quickly determined that this patient was sick. She had a blood pressure of 73 systolic, and she was diagnosed with anaphylactic shock. And she was immediately started on medications, which we typically use. Epinephrine, and the case, I will say, happened about 8 or 10 years ago. So she got epinephrine sub-Q, she got Benadryl, Pepcid, Decadron, and she got glucagon. And the reason she got the glucagon is because she was on a beta blocker medication, and the physician astutely recognized that and gave the glucagon. I think that'll probably be brought up a little bit more during the course of our trial here today. A short time later, the nurse had documented a difficult IV stick, but they had to get a different person coming from ultrasound. They eventually did establish IV access, but at that point, the patient is pale, diaphoretic, she's groggy, begins to vomit, and even on 4 liters nasal cannula, she only has an oxygen saturation of 88%. She has then a epinephrine drip started, additional glucagon, Duoneb, and the intensivist is paged. And eventually, when that epinephrine drip doesn't improve the blood pressure, they had the epinephrine drip increased. An ABG done about half an hour later, so now we're approximately an hour after she'd arrived in the emergency department. ABG was done, showing that she had acidosis, and she was profoundly hypoxemic, even on 6 liters nasal cannula. A central line was placed. That was done successfully and quickly. And because this was anticipated to be difficult intubation, in addition to the fact that she was an anaphylactic shock, hypotensive, hypoxemic, she also had a large goiter, to the point that airway landmarks, which are able to be seen grossly, weren't able to be ascertained with this patient. Anesthesia arrives, and the patient is given medications prior to intubation. She's given etomidate and sucks. The emergency physician tries 3 times intubation unsuccessfully. The anesthesiologist tries nasotracheal intubation as well as with the bougie, and none of those attempts are successful with this patient. So unfortunately, the patient is not able to be intubated. Sucks was probably used because of its short duration of action, and the patient was then allowed to have the medications wear off, was continued on non-rebreather mask, but even with that, she still had a saturation ranging from the high 80s to low 90s, even with a non-rebreather mask. Unfortunately, soon after, her blood pressure drops, 78 systolic, and then to 54 systolic. She has obvious respiratory distress. An X-ray shows that the patient has what is determined to be pulmonary edema, but it is asymmetric, and the consideration was there that this could also possibly be an infiltrate. So in addition to the patient getting some Lasix for the pulmonary edema, a Foley catheter, she was also started on antibiotics. She was started on Unison, IV, as well as Levaquin, and the epinephrine drip is now increased to 10 mics. She's on BiPAP, but it's still hypoxemic. Eventually, anesthesia places an LMA, and then they are able to intubate the patient with a bronchoscope, with the tube placed over the bronchoscope through the LMA, and they were able to do successful intubation of the patient. She's sent up to the intensive care unit. It's documented later by the anesthesiologist that the airway was complicated by edema. She has also had pulmonary edema. She had this large goiter, and it was a difficult view even with a laryngoscope. Unfortunately, in the ICU, situation worsens. She develops multisystem organ failure. She has an EF documented by echo of 15%. She's in acute renal failure. She remains hypoxemic. She has a massively elevated troponin. That morning, 9 o'clock in the morning, she develops a cardiac arrest. She successfully resuscitated initially, but with the subsequent cardiac arrest, unfortunately, she expires. So that's where we're at. This provider, as I'm guessing you'll say to yourselves, did a good or even did a great job with a really, really difficult situation. Was there opportunity to do something differently? Was there opportunity for improvement? That's what we're going to talk about over the next hour and a half. We are going to go through what actually happens at a trial. As I said initially, we're going to try to add in the medicine to that. We're going to cite some data. We're going to talk about approach to difficult airways. So some of this will be an instruction part also, but mostly what we're going to do is we're going to work through the process of what actually happens when not only there's a bad outcome, but unfortunately there's a legal action as a result of that. The allegations were 4: failure to manage anaphylactic shock, failure to emergently and timely manage the airway, failure to manage the blood pressure, and then finally, and I'm guessing most of us picked up on this, the administration of a quinolone antibiotic to the patient when she had just had administration of 2 medications from the primary care physician, which were both the quinolone antibiotic, which was the Avelox, as well as the Zoloft. So those are our 4 allegations. So I'm going to sit down as the judge here and give some instructions to you all as the jury, as well as our 8-member jury here. We can bring the lights up, please. And I have the gavel here in case not only anybody objects and I need to overrule, but in case anybody talks too long. So just a word of advice to everybody. Okay, so these statements were actually taken from not this trial, not this legal action, but a different legal action, but they're actual statements made to the jury from a judge at an actual trial. So I'm going to give you guys these instructions. Before we hear the opening statements of counsel and begin to take evidence, it will be helpful if you have some preliminary instructions to follow. It's the duty of the judge, myself, to instruct you in the law and your duty to follow the law. First of all, it is your exclusive duty to decide all questions of fact submitted to you. In connection with this, you must determine the effect and value of the evidence. You must not be influenced by your sympathy, prejudice, or passion towards any party, witness, or attorney in the case. In other words, even though Bob Culley is a fantastic guy, You can't let him off just because he's a great guy, okay? So, the attorneys will have active... Overruled. The attorneys will have active roles in the trial. They will make opening statements to you, question witnesses, and make objections. And finally, they will give their closing statements before you hear my final instructions and commence with deliberations. And again, we're all going to have the opportunity to vote on this. We're going to have the jury have their vote with, I'm appointing you the jury foreman. They will vote first, have their decision. We'll all vote, and then we'll see what the actual jury decides. And we'll have some time for question and answer towards the end here. So the attorneys will have active roles, will make opening statements, question witnesses, and make objections. And finally, they will give their closing statements. Remember that the attorneys are not witnesses. It is your duty to decide the case solely on the evidence which you hear and must not consider the statements made by the attorneys as evidence, with the exception being if the attorneys agree to establish certain evidence as being fact. The burden of proof is upon the plaintiff to prove that the facts necessary to his case by a preponderance of the evidence. And preponderance is the greater weight of the evidence. So it's the evidence that you believe because it outweighs, or overbalances in your minds the evidence opposed to it. As jurors, you have the sole and exclusive duty to decide the credibility of the witnesses, both Colin and Mike, who will testify in this case. In fact, in this case, there's also direct and circumstantial evidence. We're not going to get into that as much because our trial obviously is not 2 weeks, but only 2 hours. Those are the instructions, similar instructions that will be given to the jury. So with those definitions, Mr. Kittrick, for the plaintiff, are you prepared for your opening statement?
Judge, I have a pretrial motion.
Yes.
I would assume defense counsel will not object that we both have eminently qualified expert witnesses today, and her expert and my expert, Dr. Cade, and that we do not need to talk to the jury about their incredible qualifications.
Would you agree to that?
We agree.
Okay.
Reluctantly. We know Dr. Cade, but reluctantly, we do agree, Your Honor.
Oftentimes in the beginning of these, it's like 20, 30 minutes of establishing credibility, or that. We're obviously, going very quickly past that.
And the only other pretrial motion, Judge, is I do not think it's appropriate for the jury in the time that we have the constraints to deal with how much money they each make testifying, doing reviews of cases. There's no reason to get into that on either expert today.
Agreed.
Does defense counsel agree?
Once again, reluctantly, we agree.
Okay. All right. Fair enough. Well, with that, you have 5 minutes, Mr. Kittrick, for your opening statement.
Thank you, Your Honor. Good morning, ladies and gentlemen. Good morning, ladies and gentlemen. The defendant chose and made decisions that were significantly and substantially below the standard of care, which led to the untimely death of my client, the decedent. I represent the estate in this case. We're going to prove to you 3 things. Before I talk about those 3 things, you're going to hear and probably know just intuitively and instinctively, there's only 3 ways and 3 things that are most important in our existence on this planet Earth. 1 is we need oxygen, which means our airway must be protected at all times. 2, you do not poison a patient. If you poison any of us, we can die. And 3, we need to support the cardiovascular system, do we not? Those are the 3 main, if not the touchstones, of our existence and what you do and what the doctors are supposed to do. Sadly, we're all here 3 years after the death of my client because the doctor chose and made errors that led to all 3 of those potential devastating effects on my client. Number 1, he did not push the epinephrine and the glucagon in an appropriate way. He failed miserably and chose dosage levels that were significantly under appropriate levels. 2, he did not properly establish a safe airway. It's the only way she's going to live. And you already saw in the preliminary discussions how the blood pressure, the hypertension continued. The oxygen was not that good, and that was with support and wasn't getting any better. What was the doctor waiting for? You're going to hear evidence in this case. The average time that all of us have to do a movie and have dinner is 3 hours. We could go out, have a movie, have dinner, come back, and in that time, not one time till the end of that 3 hours was an established airway attempted. Therefore, it led to the demise of my client. That should never have happened. She should be alive today, and you should not be here today. We will prove to you by a preponderance of the evidence, which is more likely than not. That's the test. A lot of people think scientific certainty requires 90%, 100% belief in anything. The law is it more likely than not that this defendant fell below the standard of care and made choices that led to the death of my client. That will be your decision. We will prove to you all three of the plus other things that were done or should have been done did not happen. And that was the proximate cause of our client's death. And that's why you're here today. Thank you very much. Thank you, Your Honor.
Thank you, plaintiff attorney. Defense attorney, you ready for your opening statement?
Yes, Your Honor. Thank you. Ladies and gentlemen of the jury, on behalf of my client, we'd all like to thank you for your time and your attention today. No one disagrees that this is a tragic, tragic case. But the mere fact that it's a tragedy does not automatically mean that anybody did anything wrong. Yes, you've heard from the plaintiff's attorney that we all need oxygen to breathe. Well, you're going to see this theme throughout this entire trial. Their theme stops just short of a true necessity. Yes, everybody needs oxygen, but what they failed to describe to you is not only does everybody require oxygen, but you need that oxygen to perfuse your organs. You can have all the oxygen you want in your lungs by any airway, by natural breathing, by intubation, by a cryo, but unless that oxygen perfuses your organs, you will not live. So what you're going to hear today is all the attempts that Dr. Culley made in an attempt to save this patient's life. Keep in mind, this patient presented to the ER in a grave condition. She was in shock. And as you know, that means her organs were not being perfused. You're going to hear about all the heroic attempts that Dr. Culley and an entire team of experts did in order to try to save this woman's life. Unfortunately, she did die. Once again, it's a tragedy, but you cannot decide this case on sympathy. I ask you to please wait to form any opinions until you've heard all the evidence. And we are confident that once you've heard all the evidence, you will agree that this was a tragedy, but this tragedy was not the result of anything Dr. Culley did or didn't do. Thank you.
Thank you. So we proceed now, as the expedited trial, first with the plaintiff attorney has an opportunity to provide a direct examination to their expert, Dr. Cade. And the way that we've set things up timing-wise, he will have 10 minutes for the direct examination, and then Attorney Turner will have 5 minutes for their cross-examination of the expert witness for the plaintiff.
Thank you, Your Honor. At this time, we call to the stand Dr. Colin Cade. Doctor? Your Honor, he was already sworn in earlier.
Yes.
Doctor, could you introduce yourself to the ladies and gentlemen of the jury?
Yes, my name is Colin Cade, and I'm an associate professor of emergency medicine at The Ohio State University.
Doctor, it's already been reluctantly admitted by defense counsel that you're eminently qualified to testify here today. So we'll skip over all your many years as an emergency room physician and all the writings and publications and opinions that you've had throughout your career, okay? You've reviewed this case at my request, have you not?
Yes, I have.
Did you establish opinions regarding the defendant's conduct in this case?
Yes, I have, sir.
Will you agree with us that all your opinions will be given based upon a reasonable degree of medical certainty?
Yes.
Did you come to any conclusions as to whether or not the doctor fell below the standard of care and committed malpractice in this case?
Yes, I did, sir.
And it's my understanding, too, doctor, that as a general rule, you don't even do plaintiff's work. You do defense work. Isn't that true?
I tend to do a lot more defense work. That is correct.
Thank you. So it's very rare for you to even be on this side of the courtroom, isn't it?
Yes.
Can you tell the ladies and gentlemen of the jury, let's break it down. 1, 2, 3. As I talk to everybody on opening, what is your first opinion as to what the doctor did wrong?
Well, my first opinion has to do with the dosing and delivery of epinephrine. This patient presented an anaphylactic shock, and the dose of epinephrine that was given initially was a subcutaneous dose. And we have known in the literature, just general knowledge in emergency medicine, since somewhere in the early 2000s, that subcutaneous epinephrine is not well absorbed. And the correct dosing route of that epinephrine should be intramuscular, starting at 0.3 to 0.5 cc's, or 0.3 to 0.5 milligrams, because the absorption is much more rapid and consistent, especially in an anaphylactic state. The second problem is that the second dose was given sub-Q, yet the patient didn't respond, and there was a failure to do or to initiate something called push-dose epinephrine. And this is also well recognized in our literature. This is easy to do. You take a milligram of epinephrine, and you put it in a liter of saline, and then that gives you 1 mic per ml. And the dose that you give is about 1/10 of what you would give during a cardiac arrest. Cardiac arrest dose is about 1 milligram. So I can give 1/10 of a milligram or 100 micrograms IV push to this patient up front over about 2 to 3 minutes. And that is an acceptable standard. I also can repeat that push if necessary to support the blood pressure. Further, while I'm doing this, I am having a nurse mix up an epinephrine drip, but I'm not starting at 1 mic per minute. I'm starting at the correct recommended doses, which is 0.1 mics per kilo per minute, and she weighed about 80 kilos. She should have been started at a minimum of 8 mics per minute of epinephrine, and that should have been titrated rapidly to support the blood pressure with intermittent push doses. In addition, the doctor did correctly recognize that this patient was on a beta blocker, yet he only gave 4 milligrams total of glucagon over a number of hours. The correct dose of glucagon in a patient who is on beta blockade can start at 1 to 5 milligrams, and that can be repeated up to 15 milligrams up front. And when a drip is started, it's started and titrated to effect with almost no ceiling. This is to counteract the effects of the beta blocker that she was on. She was on propranolol, and to allow the epinephrine to do its job. Those are two things that are very, very important that this physician missed with regard to doing what we call cardiovascular support to maintain perfusion and oxygenation of the organs. Because they're so profoundly vasodilated from the event, and their blood vessels are so weak that you have to provide the maximum amount of cardiovascular support, and that was not done in this case.
Doctor, did the care in every single point you just told us about?
Absolutely. These are published doses that are recognized. They are published by societies. They are not foreign to any emergency physician who has gone through residency training and is a board-certified residency-trained emergency physician.
He should have known these things then, is what you're saying?
Absolutely.
Doctor, I understand you have other opinions regarding the airway protection or the failure to do so. Can you tell us about those opinions, please?
Yes, I can. For starters, this patient was a difficult intubation, and I think everybody could acknowledge that this was going to be a difficult intubation. However, when he failed after 3 attempts, and his anesthesiologist failed with traditional methods, ultimately having to have an ENT doctor place an LMA, a laryngeal mask airway, and in particular a special kind called an intubating LMA, more than 3 hours after this patient arrived in the emergency department. And as I recall from the testimony, the doctor was not familiar with how to use an intubating LMA. Anybody?
You're talking about the defendant?
I'm talking about the defendant.
The defendant did not know this?
The defendant did not know how to
Objection,
place an
objection,
intubating LMA
speculation.
mask
There's no
airway.
foundation for this testimony.
Objection sustained.
Continue on, doctor. Continue on, doctor.
So once he recognized that this was a failed airway, and not only just a failed airway, but a disaster waiting to happen. Waiting to happen because, number one, this airway isn't going to get any larger as the swelling increases. It's going to become progressively harder. Number two, he saw an x-ray that he misinterpreted as an aspiration pneumonia that just rapidly developed out of nowhere, when what this should have been recognized as is ARDS, and it's from leaky capillaries in the lung. And we know this patient needs positive pressure ventilation with a controlled, secured airway, and that can be done on a ventilator most efficiently. Further, if he was worried that he was unable to get this airway, and he was worried that maybe there was a big vascular structure there, Any board-certified residency-trained emergency physician who completed residency within the last 10 or 15 years should be intimately familiar with how to find the cricothyroid membrane with an ultrasound. And if he's worried about cutting into a vascular structure doing a cricothyrotomy, if he identifies even a small bit of that membrane, he can easily perform another procedure that is classic in emergency medicine, which is a retrograde intubation. And that is very simple to do. You take a needle, fill a syringe with a little bit of saline, push the needle through the cricothyroid membrane, and by the way, you can't push too deep because it'll never come out the other side. And you aspirate air bubbles. Then you run a guide wire through that needle and out the mouth or nose, mostly out the mouth, and then you put the ET tube on that and slide it back down in. That will get rid of a lot of the problems that occurred in this particular case. And this doctor doesn't even have to worry about cutting into vascular structures. In retrograde intubation, although there is a kit for it, every board-certified residency-trained emergency physician knows that you can use a central line kit because the guide wire is long enough and the needle is big enough to allow that improvisation in order to get that guide wire out the mouth and to get that airway secured definitively. Those are many of the options that were available for this physician. If he had put in an intubating LMA, an intubating LMA is designed specifically not only to protect the airway temporarily, but to provide a passageway and a mechanism by which a soft ET tube that comes with the kit could be passed directly into that airway. And I find it hard to believe that in a hospital that has an anesthesiologist on call, that we don't have somebody there that knows how to use a fiber optic intubating process, except for an ENT doctor who comes in 3 hours later in this process.
Doctor, did the defendant do any of the techniques that you just talked about, for example, the retrograde intubation, which I understand you just need a triple lumen kit, potentially?
Correct.
Did he do that?
He did not.
What about the cricothyrotomy?
He discussed the cricothyrotomy, but was afraid to do an open cricothyrotomy because of potential for vascular structures that could have bled.
Would the ultrasound use have taken away that worry?
I think it would have taken away the worry very nicely because he would have been able to identify the tiny area that he needs to stick a needle into. Yes, absolutely.
And just so we're all clear, doctor, to do any of these techniques, it wouldn't have taken 2-3 hours, would it?
Not under the right circumstances, that's correct. It should have taken less than 5 minutes to be able to establish.
Less than 5 minutes?
Absolutely. Because central line kits are easy to find. The technique is a very easy technique that we review all the time in emergency medicine. It's reviewed on all the journals and all the CME programs, how to do these techniques.
From 12 to 2:30, 2.5 hours, did the defendant do any of these techniques to help save my client?
He did not.
I understand you have 2 other opinions I want to jump to, doctor. One is another drug that apparently was given that should not have been given to the decedent. Tell us about that.
In the discussion in the witnesses' statements and in the discussion, there was some concern or some talk about the use of moxifloxacin in this patient. However, the physician was not concerned that this was an issue because the patient had had doses of moxifloxacin in the past. And anybody who has attended medical school or PA school knows that the first time you take the drug, you have potential for sensitization. Doesn't mean the second time you're going to have anaphylaxis. You can have that drug a couple of times before you become sensitized to that drug. And then on the next time, while you have pre-existing antibodies that are attached to mast cells, you receive that drug, very highly antigenic drug, and you open up the mast cells and you spill histamine into your system in an uncontrolled fashion. So not only did this patient most likely, statistically speaking, most likely have a reaction to the moxifloxacin and not Zoloft, which is almost never implicated in any anaphylactic reactions, he gave the patient, while they were decompensated, a dose of a similar drug for which we know there is cross-reactivity. And likely, at that point in time, we saw an increase in vasodilation and we saw more cardiovascular collapse as the patient progressed on in the ICU. So he essentially poisoned a patient who was already poisoned by a particular medication. And he should have known, or should have known, that you cannot give the same class of drug for this. And he should have recognized this is not an aspiration pneumonia that develops suddenly minutes after an intubation attempt. This is ARDS as a result of leaky capillaries and histamine release.
Dr. Ward, we have 1.5 minutes. I understand that there was a failure, one more failure that was very important, in your opinion, regarding a transfer. Tell us about that. We have 1 minute to talk about it.
Yes, this patient's in or near a large set of medical centers, and the minute he recognized that this was a failing anaphylaxis, after potentially, although he didn't do it, potentially maximizing the doses of medications, this patient was a perfect candidate to go on ECMO. Extracorporeal membrane oxygenation. This patient doesn't even need a heart, a lung, or a blood pressure at that point. They can go on a device that will oxygenate their blood and take over their cardiac function and provide the oxygen and the essential perfusion that this patient was not getting during this massive anaphylactic event. He should have recognized this was a failed, decompensated, uncontrolled anaphylaxis and transferred this patient across town. And if the argument was the patient didn't have a secured airway, well, the patient didn't have a secured airway anyway for 3 hours. He could have transferred across town or activated an ECMO unit within his own hospital if it existed. Otherwise, the number is 614-293 ECMO.
Doctor, one last question, so we're all clear when the jury goes to deliberate behind closed doors. Did these failures, the choices the defendant made, lead to the death of my client?
Very clearly, they did.
Thank you, Your Honor. Thank you.
Thank you. We'll have 5 minutes for cross-examination by the defense.
Thank you, Your Honor. Doctor, we agreed we wouldn't discuss how much you're getting paid, but you are getting paid, correct?
$0.00, I believe. Was
Have you ever been named as a defendant?
I have one time been named as a defendant.
And so certainly you would agree with me that the mere fact that you have been named as a defendant does not automatically mean that you have deviated from the standard of care, does it?
Not in my case.
You mentioned epi and glucagon to the ladies and gentlemen of the jury. The standard of care you recited to the ladies and gentlemen of the jury, that was not the standard of care in 2008, was it? Was it? It wasn't, was it?
Objection, Your Honor. We've established that the standard of care is today's standard pre-motions.
No, Your Honor, we did not establish such a thing. The standard of care is always
3 years ago.
based upon evidence at the time.
Please don't make me have you approach the bench for discussion.
No,
Please.
Your Honor, I will withdraw the question.
Thank you.
Doctor, you would agree with me that medicine evolves over time.
Yes, I would agree with you.
And you would agree with me that a reasonably prudent physician will practice medicine within the standard of care based upon the evidence-based practice at that time.
I can't agree to that because at the time, sub-Q epinephrine was not given. That changed in 2002. I believe this case was 2008, so I cannot agree to that statement as a blanket statement.
You would agree with me that medicine is practiced on a case-by-case basis.
I would agree that it's practiced on a case-by-case basis. However, it does need to follow certain guidelines and standards that are taught in all residency programs.
Did this patient present in anaphylactic shock?
Yes.
And it was anaphylactic shock because one factor that determined it was shock was she could not maintain her blood pressure.
That is correct.
And that was evident when she first arrived to the ER, correct?
Yes, I believe that is correct.
And one of your criticisms was that Dr. Culley administered Levaquin.
Later on in the course, yes, after a number of hours of attempting to get the blood pressure up, yes, that's correct.
Right, and you say it was a deviation from the standard of care because everybody knows that the Levaquin was just going to make her condition worse, correct?
I would say it has a strong potential to make her condition worse, as evidenced by her ultimate multi-system organ failure that occurred after she received the drug.
Oh yeah, and as evidenced by the fact that her blood pressure stabilized after the Levaquin was administered, correct? You recall that, right?
That was only after he attempted to get the epinephrine up to the highest possible level, 3 hours too late.
Correct, though, you will agree with me that 30 minutes after the Levaquin was administered, her blood pressure stabilized.
That's correct.
Correct. We talked about airway. You would agree with me that a reasonably careful, prudent physician will practice medicine that is indicated. You don't just do something just because it can be done, do you?
No, you do something because you know either it's the right thing to do or you, in your best judgment, you anticipate where the course of this is going and you make a decision based on that.
And in this particular case, how many attendings were at the bedside in the ER?
There were 3 attendings initially.
Mm-hmm. And those attendings included an ER attending, a pharmacist that stayed at the bedside, as well as an anesthesiologist, correct?
Yes, there was an anesthesiologist present.
And of the 3 attendings at the bedside, not one of them believed that an LMA or a surgical airway or a CRIDE or fiber optic was indicated before it was done, did they?
Objection, Your Honor. He doesn't know what they believe. That's an inappropriate question.
Objection sustained.
Does the documentation indicate that any one of those physicians at the bedside felt that, did they document? Was there any documentation that any expert at the bedside recommended an attempt at an LMA, fiber optic, surgical CRIDE, any of those items?
They did not recommend those particular procedures, and I cannot attest to why not, why they didn't.
Anything else? Thank you.
Excellent. So thank you, Dr. Cate, for your testimony. We are now going to move to the defendant. For the defendant, we'll actually change the time slightly. We'll have 10 minutes for the direct from their defense attorney, and then 10 minutes for the cross, and then we'll proceed to the defense expert witness before the closing statements.
Your Honor, at this time, the defense would like to call Dr. Cawley to the stand. Oh, you never stand close to the jury. Dr. Cawley, would you please tell the ladies and gentlemen of the jury about your background?
I am a emergency medicine physician. I attended West Virginia School of Osteopathic Medicine and attended residency at Adena Regional Medical Center in Chillicothe, Ohio.
And can you tell the ladies and gentlemen of the jury how many patients with anaphylaxis you had treated prior to this patient?
I'm not exactly sure of exactly the direct number, but at least 20.
And let's talk about this particular case. How would you describe this patient's condition when she first presented to the ER?
When she first presented to the ER, the patient was initially seen by the physician assistant who recognized the extremis that the patient was in and actually called me to bedside. At that time, the patient was having some difficulty breathing and was complaining of nausea and was what appeared to be an extremis.
Now, this was the first time you had met this patient?
It was.
And so, as with every ER physician that you encounter for the first time, you have to start at ground zero, correct?
That is correct.
And as an emergency medicine physician, how do you treat a patient who presents to the ER with the symptoms that this lady presented with?
So when I start, just like we were taught from the very beginning, we look at the ABCs of emergency medicine. So we look at airway, we look at breathing, and then we look at circulation.
And is that how you treated this patient?
It is.
And what was your first priority for this lady?
So initially, again, the airway was addressed. The patient was placed on oxygen. She had vital signs obtained. And then subsequently, we evaluated her circulation after.
And why didn't you attempt to intubate her immediately?
Can you repeat that question?
Why, when she first presented to you, why did you not attempt to intubate her immediately?
She was maintaining her O2 saturations at 99% on 2 liters nasal cannula. I did not feel as though we were losing her airway at that time. She was able to speak to us. She was able to give us guidance to these things. And I did not feel it was emergent at that exact moment to take control of her airway.
What did you do for this lady?
So initially, we placed an IV. Again, we had some difficulty placing the IV. But she was given a dose of Benadryl. She was also given some steroids called Decadron to potentially reduce any swelling that was there. In addition, she was given a medication called Pepsid, which also can help with these symptoms. It was at that time that we discussed giving epinephrine as well.
And did you eventually give her epi?
We did.
And how did you choose the dose and the route of epi that you administered?
So the standard dose for epinephrine is 0.3 milligrams to 0.5 milligrams. And at that time, it was standard practice to give subcutaneous or intramuscular.
And has the evidence-based practice of medicine changed its thought about the route of epi nowadays?
Yes, it has. Now, intramuscular epinephrine is what is considered standard.
Okay. And did you give her, what else did you give her besides epi?
We also chose to give her glucagon. This patient was actually on a beta blocker, and we did not see a direct response with the epinephrine. So our concern is that with giving her the epinephrine, she was not having the proper response. So at that time, we decided to give her glucagon, which is a well-known medication to help and assist with the response to epinephrine.
And how did you decide upon the dose and the route of administration for the glucagon?
So that was chosen by the pharmacist actually at bedside that was with us.
How often have you called the pharmacist and asked the pharmacist to stay at the bedside?
Usually not very often. I will call a pharmacist when I am out of my comfort zone when it comes to certain dosings of medications. And when I get into more of a complex patient, my worry is that I was going to have to give a medication that I was not as familiar with, and I wanted to make sure that I was giving the proper dosing.
So what time did you first attempt to intubate?
I believe it was right around midnight.
And what was the indication? So she'd been there for how long when you first attempted intubation?
I believe roughly 1 hour that she had been there since she had presented initially. I believe at about 10:58, 10:59, and around midnight is when we attempted our intubation.
And what had changed in her condition that prompted you to attempt intubation?
So the patient slowly began to increase her oxygen demand and began to become a little more somnolent, meaning she was a little more sleepier than she was previously.
And what other medications did you administer? We've talked about the epi, we've talked about the glucagon. What other medications did you administer in the ER?
So we also administered, as we had discussed, the Benadryl, the steroid, Decadron, and Pepsid. In addition to that, when we attempted to intubate, we utilized the etomidate and succinylcholine. And then subsequently, during the course, we also provided Unison as well as Level.
So before we move on to the antibiotics, I want to talk about the intubation. Who attempted the first intubation?
I did.
And how many times had you intubated prior to this event?
I cannot, I think this is an innumerable amount. I have records from residency of how many times I have intubated, but since then I can't keep a record.
And you did you made 3 attempts to intubate this lady, correct?
That is correct.
And why did you do 3 attempts? Why didn't you pass it off to somebody else?
Well, at the time I was the attending physician in the room. And actually on my 3rd attempt, I had paged anesthesia due to the difficulty that I was obtaining with her airway. And I felt very comfortable with managing airway, given the number of times that I had intubated people in the emergency room.
And then did anesthesia arrive?
Anesthesia arrived soon after the 3rd attempt of intubation.
And how many times did anesthesia attempt to intubate this lady?
Anesthesia also attempted 3 times, and I believe there was another time that was not documented, where they actually attempted a nasal intubation.
So there were 7 attempts to intubate this lady, correct?
That is correct.
And after those 7 failed attempts, was there any discussion in the ER by the physicians who were present regarding an LMA or a fiber optic approach or a crike? Was there any discussion about what to do next with the airway?
So the patient was starting to wear off with her sedation at the last attempt from the anesthesiologist. It was discussed at that time numerous ways that we can go about controlling her airway. And after that, we came to the conclusion that she was maintaining her oxygen, she was protecting her airway, and we decided to take a step back at that time with managing her airway and address the major concern of her hypotension at that point.
So when we're talking about the hypotension, you've heard from the plaintiff's expert that Levaquin was contraindicated and may have contributed to her hypotension. Tell the ladies and gentlemen of the jury, were you aware that this lady had been prescribed Avalox?
I was. I had actually seen that the patient in the triage note had been prescribed Avalox in the past.
And how many times had she received Avalox in the past?
I believe 3 previous times, but we'll have to look at the record.
So this administration was her 4th time she had received Avalox.
To the best of my recollection, yes.
And you're aware that the medical literature indicates that it's really rare that the fourth administration of Avelox would cause an anaphylactic shock, correct?
That is correct.
Doctor, did you meet the standard of care in your care and treatment of this patient?
Objection, Your Honor. This witness has not been established to be an expert witness on the care he provided.
Your Honor, it was plaintiff's pretrial motion that we would dispense with qualifications, and my expert, and Dr. Culley is obviously, as evidence rule 702, he has specialized education, knowledge, training, and experience, which qualifies him to be an expert.
Let the record reflect the defense never said this would be an expert of his own expertise.
Your Honor, this is,
Everybody move to strike.
Everybody knows this is how it's done, Your Honor.
I will have the jury take into account both of the plaintiff and defense objections, and I would ask you to ask him this question again, but rephrase it in a different way.
Exactly.
Did you do anything wrong?
Objection, Your Honor. Why don't we just ask him if he wants to? Why don't we just ask him if he wants to pardon himself?
Did you do anything wrong?
I believe I cared for the patient the best I could.
Have you thought about this since this event?
Every day.
And in hindsight, we all know hindsight's 20/20. In hindsight, would you have done anything different?
I do not believe I would.
Thank you. Nothing else.
Thank you, defense counsel.
Thank you, Your Honor.
Plaintiff counsel have 10 minutes.
All right.
As opposed to the typical 5 we've been doing. 10 minutes for the cross-examination of our voluntary defendant position.
Thank you, Your Honor. Ladies and gentlemen. Counsel. You know, I'm really surprised that we're here, Doctor. You've come before us admitting that the patient, my client, which is now the estate, was in extremis, was in grave condition, correct?
That's correct.
I mean, she's in bad shape already as soon as you see her, right?
That's correct.
So there's no mystery that, you know, all of a sudden she gets worse 2-3 hours later. She's coming in serious condition, right?
That is correct.
And don't you have a duty to rule out the most life-threatening conditions at the top of your differential diagnosis?
That is correct.
So the first thing you're trying to figure out is, what's going to kill this patient? I've got to rule that out. Is that correct?
That is correct.
Now, you already knew anaphylaxis was apparently apparent, right?
It did appear to be anaphylaxis.
And you're quite familiar, having done at least 20 patients according to your testimony earlier.
That is correct.
And anaphylaxis, although rare, the last thing you want is a patient to die from anaphylactic shock or anaphylaxis, correct?
Correct.
That is not good, right?
That is correct. I do not want anybody to die.
Now, I think you mentioned earlier, well, we'll get to that in a moment in terms of what was going to be apparent or not to you, Doctor. I'm a little confused here because the record, I think you said you weren't worried about her airway initially. Did you say that?
No, I did not say I was not worried about her airway.
Oh, you were worried about her airway then?
Absolutely.
Aha. Okay, because I thought earlier you said, well, we backed off. We were having so much trouble with her airway, we even backed off on her airway protection and focused on the hypotension. Isn't that what you said?
I did not say that we would.
You said backed off, did you not, sir?
I did.
All right, let's come back to that in a moment. So wasn't one of her initial complaints, Doctor, throat tightness? The very first thing she said is, my throat is tight.
Yes,
and that is not a good sign for breathing through the airway here, is it, sir?
That can be a troublesome finding.
Well, in fact, it was, wasn't it?
That is correct.
You tried to intubate her and failed.
That is correct.
So now we got a problem with somebody's coming in extreme condition. So you've got to rule out the worst possible thing that could kill her. And you already know it's not some rare disease, correct?
That is correct.
It's not a rare disease. This is an anaphylactic response. She's saying, hey, I can't breathe. I'm tight. She's dizzy, correct?
Yes.
She doesn't have 100% oxygen. She does not have 100% oxygen, does she?
She was not hypoxic at that time.
She had lower than 100% oxygen when she came in.
Most people do not actually sit at 100% oxygen. Most average people stay above 94%.
Well, there was times when she had a mask on that she was 88 to 92%. That's not good, is it? That shows impending airway problems, does it not?
That is not when I first met her and when we made these decisions. She was 99% on 2 liters nasal cannula.
So she came in, she can't breathe well with the tightness. She's got a rash. She has some SOB, shortness of breath, correct?
That's correct.
She's already saying, I don't feel well, and you're going, man, this is a bad situation. And I assume in your mind you're thinking, this is bad. We got to figure out what to do.
Absolutely. That's why pharmacist was called and why there were multiple staff members in the room.
Now, did you heard my expert, Dr. Cade, earlier? Did you not, sir?
I did.
He told us all that the epi-push you gave was wholly inadequate, that it was substandard based on a 2001 report that's been the standard of care in the profession for many, many years. Are you aware of that?
I am not exactly aware of that particular journal.
The Allergy Clinical Immunology Journal, you do not know?
I'm not familiar with the exact, I believe I've heard of it, but if you would like to give me some time, roughly an hour to read through it, I'd be happy to do so.
Well, isn't that a standard document and journal for all ER doctors to at least read or be aware of for your standard of care in the practice in emergency room medicine?
As mentioned before, that at the time, subcutaneous epinephrine as well as intramuscular epinephrine was an acceptable route of administration. And subsequently, intramuscular epinephrine has become what is considered the standard of care.
Well, let's talk about that. I'm glad you brought it up. You said when you gave her the epi, it didn't do a whole lot of good, didn't you?
That is correct.
And that's exactly what Dr. Cade said, that your dose was so low that it wasn't going to do any good, and that's exactly what you found to happen, isn't it? Isn't that true?
It is correct, but...
And therefore, you could have...
Objection. Let him finish his answer.
This is cross-examination, counsel.
Your Honor.
Your Honor.
He's entitled to answer. He's entitled
He
to
answered
answer.
the question. I'm moving
Let
on.
him finish his answer.
He answered the question. He already
Let him
agreed.
finish his answer.
Well, I found you both in contempt. The witness will have the opportunity to finish his answer.
Well, as soon as you saw that you gave her this epi-push and it didn't do what you were hoping it would do, there wasn't an efficacious result, you could have done exactly what my expert, Dr. Cade, said, which was to push up to 10 mcgs at a time and even up to 100 mcgs over 3 minutes. Did you ever attempt to do that to save her life?
With pharmacy at bedside, we decided that we placed the patient on an epinephrine drip.
Now, my question, sir, is did you ever decide right there as the attending, which I think you said you were the attending, did you ever decide to say, hey, this is not working, I'm going to push this up to 100 mcgs over 3 minutes? Yes or no?
No, but.
Then, you know, I find this interesting. You bring all these people in the case, you got all these doctors, everybody's sitting around watching this patient go down the tubes. Now, let me ask you this. Have you ever heard of the neuroscience groupthink? Have you ever heard of that, the issue of groupthink and the demise of decision-making with groupthink?
I have heard of this, yes.
Which means that if a whole bunch of people are standing around, you're trying to get opinions, that a lot of people aren't going to speak up. That everybody kind of goes with the flow because they don't want to be considered, the outsider, the naysayer. So you have all these doctors. Did you ever appoint somebody like Dr. Cade in the group and say, hey, I want you to be my naysayer? We're thinking this, but what do you think? You play devil's advocate with us. Did you do that at any time to get other opinions to try to save this person's life?
It's a regular thing in my practice and standard in my practice to discuss the case with multiple people. That includes the other 2 physicians that were in the room by the end of this case, as well as the nursing staff that was there as well. Multiple attempts and conversations were had and discussions were had during the care of this patient. And that is a standard that I carry through all of my patient care.
That's not my question, doctor. My question is simple. I'll write it down if you want me to. Did you at any time ask Dr. X, Doctor, I want you to be the naysayer in this group think to make sure we don't miss anything and give us the other side and push it so that we make sure we consider doing other things to save and protect this patient? Did you do that?
No, I did not appoint anybody for that particular role.
You know how to do a microsterotomy?
That is correct.
Did you do it?
I did not.
You know how to do a retrograde intubation?
Yes, I do.
Did you do that?
No, I did not.
Did you do a fiber optic intubation using a scope?
No, I did not.
Did you do a glide scope with a sitting position?
No, I did not.
Did you do an air track in a sitting position?
No, I did not.
Did you know how to do any of those things?
I do know how to do them, as well as anesthesia at bedside with me during the management of the patient's airway.
But you chose not, it's fair to say, as you talked to us today in court, you chose not to do any of those techniques, correct?
We chose...
No, I'm asking you. You chose not to do any of the techniques that Dr. Cade told us about. Isn't that true?
Per our conversation with discussion with anesthesia at bedside, we chose not to perform this as a group together.
So basically, you did not make your own decision, that you decided to have this a group decision? Is that what the record says?
No, that is not correct.
In fact, you're the attending, which means you have direct responsibility. Isn't that true, doctor?
That is correct.
So we did this, we did that. That is not really appropriate here, is it, sir? This was your decision under the circumstances. You could have made these decisions, you could have done these techniques, and you did neither of those. True?
That is correct.
Tell us about transferring her to ECMO. Dr. Cade said you should have transferred her to ECMO. If you all didn't know what was happening, why not get her to a center, because this was only 10 minutes away, Riverside, Ohio State. Could have done an ECMO to save the... Why didn't you do that?
So at the time in 2008 when this case was carried out, emergency department ECMO was not actually in place. The patient care was also discussed with the intensivist. The intensivist also did not recommend ECMO at the time.
Well, you've got a drug that you gave her. Certain drugs can be poison, right? We could take a drug, maybe it doesn't hurt us the first time, maybe it doesn't hurt us the second time, might start hurting us the third, maybe the fourth time it could start hurting us, correct?
I agree that some drugs can be poison.
You've heard Dr. Kay's testimony that you gave her poison on top of poison in this case, didn't you? You gave her a drug that she already had a problem with, on top of everything else she had going on that wasn't going well. You gave her another drug and didn't take physical care of her, doing any of the techniques, decide to push a few drugs, not even enough, and then you decide, well, there's not much we could do. 3 hours later, after we all could have gone to a movie, had dinner, they finally do a technique, and by then, she's in desperate, desperate shape. She has organ failure, and she ultimately dies. Isn't that true, doctor?
When I first saw this patient, I did everything in my power to treat this patient with everything that I could do at that time, with every medication that I believed at the time to be correct. This is a very difficult situation. This patient had what is called refractory anaphylaxis. And despite numerous medications, the patient did not improve for quite some time.
So,
As far as giving the levofloxacin that you were referring to as poison, the patient actually stabilized after the patient had received this medication. This was not before the patient started on both epinephrine drip as well as a levofed drip.
I know I'm out of time. You're not trying to tell us that my client was in such bad shape, she was just a dead woman walking, are you, sir? You're not.
No, I'm not.
Okay, thank you.
Thank you, Dr. Cully. We'll next have the defense call their expert witness, Dr. Michael Palachi.
Yes,
stand.
yes, thank you, Your Honor. The defense would like to call to the stand Dr. Palachi. Am I pronouncing that right? You can clap. Thank you, doctor, for being here. Would you please tell the ladies and gentlemen what it is you do for a living?
I'm a practicing emergency physician and a emergency medicine residency program.
And on occasions, you testify as an expert.
On this occasion, this is actually the first time that I testified as an expert. But when I reviewed the facts of this case, I was so compelled by the case that I decided that I would testify.
Now, how long have you been an emergency medicine physician?
I've been out of residency for about 17 years and was a resident.
So tell me, doctor, tell all of us, doctor, have you ever in medical school, residency, in your career, have you ever appointed a naysayer?
I can't say that I have.
Have you ever heard of such a role in emergency medicine or any medicine for that?
I have heard of that once or twice recently. In 2008, I would be relatively certain that I would not have heard of it at that point. But even in 2018, while it is it's arguable that could potentially be beneficial today, that's still not the standard of care.
Do you agree it was within the standard of care for Dr. Coley to diagnose this patient with anaphylaxis?
Absolutely.
Anaphylaxis shock.
Absolutely.
And why? What made that the appropriate diagnosis?
Well, to diagnose anaphylaxis, 2 of 4 things are required. There's a few different definitions, but the best way to summarize those definitions is that we need skin findings, decrease in blood pressure, involvement of other organ systems, the respiratory system, the GI system, and the patient clearly met those criteria. Anaphylactic shock occurs when that anaphylactic reaction progresses to the point that we're not perfusing our organs well, and they're hypotensive. Usually they're not mentating very well, they're not able to think very clearly, and their other organs, their gut, their kidneys, their heart are not perfusing well.
What is the mortality rate for a patient in shock, regardless of the cause of shock?
Well, I can't give an answer to that because each different classification of shock has its own mortality rate. Anaphylactic shock is rare. Anaphylactic shock occurs in less than 1% of all allergic reactions. When you do develop anaphylactic shock, though, the mortality is significant. I don't have those numbers on the call.
Is it a greater than 50% chance that a patient will die once they reach this stage of anaphylactic shock as this patient presented with on this day?
In patients with refractory anaphylactic shock, the mortality would be expected to exceed 50%.
Do you agree it was within the standard of care for Dr. Coley to not immediately attempt intubation as soon as this patient presented?
Not being at the bedside is difficult to really criticize that decision. Within the standard of care, absolutely. What Dr. Cully decided at the time that he evaluated the patient was that although there was the potential for deterioration of her airway and the potential for her to lose her airway, that at the moment that he saw her and at the moments that subsequently he continued to reassess her, that the risks of proceeding with an attempted intubation, the risks of giving a patient a paralytic drug that would make her stop breathing, and that would potentially be harmful if he's not able to get an airway quickly. The risk of being able to get a surgical airway if that failed, that the risks associated with the intubation outweighed the potential benefits of the intubation. It's not to say that he didn't recognize the risks of waiting. It's to say that the decision was made that the risks of waiting were not as great as the risks of proceeding, that the benefits of acting quickly were outweighed by the potential risks of acting quickly at that moment. That's a fluid situation, it's dynamic, but at the time that he evaluated her, that's a decision that he made, and not being at the bedside, I think it would be inappropriate to challenge that decision.
Did Dr. Coley meet the standard of care in his administration of epi for this patient?
If the case occurred last week, the answer might be no. In 2008, that's a different answer. The answer is yes. Today, it's established an intramuscular epinephrine in anaphylaxis is the most appropriate route to administer epinephrine. In 2008, that was an evolving opinion. I actually, in preparation for today, was able to find Rosen's textbook of emergency medicine from 2006, which would be the most recent edition at that time. And in that textbook, pretty widely accepted textbook, they stated that in patients who are hypotensive, subcutaneous dose may be more erratically and slowly absorbed, and intramuscular administration may lead to more rapid absorption of the drug. That was not in the guidelines at the time. There are multiple guidelines, but at the time, subcutaneous epinephrine was still an acceptable treatment. In terms of the dosing of epinephrine, there were also different guidelines at that point. There were European guidelines that were very aggressive that recommended starting at about 10 micrograms per minute. The American guidelines at that point that I've been able to identify recommended a starting dose of 1 to 4 micrograms per minute, titrating to a maximum of 20. So starting between 1 and 4 micrograms per minute in 2008 was an acceptable place to start.
Did the administration of Levaquin and or Unison prolong or worsen this patient's anaphylaxis?
I don't see how that case could possibly be made. When 30 minutes after the Levaquin was administered, the patient's blood pressure was up over 110 and didn't destabilize again until she put it in the ICU.
Was it within the standard of care for Dr. Coley to eventually attempt intubation of this patient?
Yes.
Why?
As the case evolved, Dr. Cully made the determination that he needed to get control of her airway as her clinical status worsened. That, again, is a decision that's made by a clinical expert, a trained physician at the bedside. And I think that based on my review of records, that seems like the appropriate decision at the time that he made it.
Is it a deviation from the standard of care to not get the endotracheal tube in the trachea on the first attempt?
No, it's intubation is a difficult procedure that requires a lot of training, and even once trained, expert physicians, expert airway management physicians can miss on the first attempt, even on the second attempt.
Is the deviation from the standard of care not the misplacement, but the failure to recognize misplacement?
Yes.
And that's why the standard of care requires vigilant assessment of the airway after an endotracheal tube is placed.
Yes.
Was it within the standard of care for Dr. Cully to, after his 3 attempts, to then pass off the intubation attempts to the anesthesiologist at the bedside?
There were multiple options available at that time, and that was one of them. Whenever there's a failed attempt at an airway, the standard of care and the standard teaching, standard practice of most physicians is to try again by a different mechanism. Sometimes that different mechanism just involves changing the blade, as Dr. Cully did. Sometimes that different mechanism involves an alternate technique, possibly tracheal manipulation. Sometimes it involves advanced airway equipment. Another accepted methodology is to give an attempt to another individual and another set of eyes, another set of hands. After his 3rd attempt, he passed off to another expert at the bedside, which is certainly within the standard of care.
After the 6 or 7 attempts to intubate this patient, did the standard of care require this patient to have an LMA placed or a surgical airway or fiber optic?
Look, this is where the art of medicine comes into play. There's no guideline, there's no algorithm, there's no cookbook that tells you what to do with a patient who's difficult airway, an anaphylactic shock, with hypotension, with either aspiration pneumonitis, ARDS, pulmonary edema, or both, who has borderline but adequate oxygen saturations, who also has a giant goiter unit. There's no guideline for that. There's no algorithm for that. There's no specific concrete recommendation what to do in that scenario. This is where the collective wisdom and the collective experience, the collective expertise of the caregivers at the bedside needs to be applied to give that patient the maximum chance for survival. That's exactly what happened. There were 3 experts at the bedside, an emergency medicine physician, an anesthesiologist, and a critical care physician. Those 3 experts put their heads together, analyzed the situation, came to a decision based on their collective expertise, and acted, and that's completely appropriate.
Hypothetically, if there had been a naysayer at the bedside, do you think the naysayer would have recommended anything that wasn't done in this case?
Objection, Your Honor. First of all, those opinions were supposed to be disclosed. Now she's getting into hypotheticals. That's not what the testimony should be about here today.
Objection sustained.
Your Honor, you didn't even give me a time to answer. It's plaintiff's counsel that brought up naysayer. I'm just following up on his questioning.
It's a hypothetical, Your Honor. That's not what this is about.
Agree this is hypothetical. 30 seconds more for completion of your examination.
Did the standard of care require Dr. Cully or any other physician at the bedside to transfer this patient or to put her on ECMO?
No, ED ECMO in 2008 was not even a consideration. It's still an advanced concept that's only available in select emergency departments now. Could have been a consideration in the ICU. It could have been a consideration in the ICU, yes, but the intensivist at the bedside in combination with Dr. Cully did not think it was warranted, and that's the decision they made based on the knowledge they had available to them in 2008.
Do you have an opinion to a reasonable degree of medical probability whether or not Dr. Cully met the standard of care in his care and treatment of this patient?
Dr. Cully absolutely met the standard.
Thank you.
Plaintiff, you'll have 5 minutes for cross-examination of our defense expert witness, Dr. Blatchett.
Thank you, Your Honor.
We'll then proceed to closing statements and see what the jury has to say.
Doctor, I want to follow up on your very first opinion here, which I'm kind of astounded by. Basically, you admitted to all of us that my client was essentially a dead woman by more than 50% chance. In other words, it was more than 50% chance she was going to die. That's what you said, isn't that true? When she walked in the, well, she didn't walk in, when she came into the ER.
No. When that percentage rose was when she was refractory to multiple interventions. Refractory anaphylactic shock has a very high mortality. That's not to say that anybody's a dead woman walking, it's to say the odds were stacked against her significantly.
What time was the refractory diagnosis made?
I'd have to review the record, sir, but after multiple doses of subcutaneous epinephrine were given and then an epinephrine drip was started and escalated at the point that she was not responding to that therapy, at that point, she would meet the definition of anaphylactic.
Was within,
Anaphylactic shock.
that was in the first hour, wasn't it?
I'd have to review the record.
I thought you reviewed the record so you could be prepared to testify here today. Doctor, are you saying you're not even prepared?
Objection. Argumentative. He's not expected to memorize the records.
He could bring the records with him, Your Honor.
Your Honor, I have the records. I'd be happy to give him the records.
Counsel, could you tell me what
Well, it's within, if I tell you it's within the first hour, you can't disagree with that, can you?
Objection.
confirm it, but I won't disagree.
All right. Did you ever tell my client or the family within the first hour, if you do this epinephrine drip, or the defendant did, and you do all this stuff and she's still getting worse, did you say, by the way, I think you're going to die, or it's not likely you're going to live? Did the defendant ever say that? Did he ever have the courage to say that to his patient?
Objection.
Does the record ever reflect at any point in time in the first 2 hours when she's in the emergency room that she's likely to die and the family's been informed that she's likely to die, or that we told the patient she's likely to die, and to start taking emergency measures with the chaplain and with the living will people and the family? Was that ever in any record in this case?
Objection. Argumentative and compound.
I will overrule. There's objective statements in the record, and the witness can answer the question.
There was multiple entries in the record reflecting that Dr. Culley spoke with the family about how sick she was at various points along the ED course. And in Dr. Culley's deposition, he reflected this as well, that there was continuous communication with the family.
That's not my question, doctor. My question, I would hope he's talking to the family. She's already in extremis. He told us that, right? My question is, did the defendant ever say to his patient or the family in the first hour when things were not working well, it doesn't look good, you're not likely to live, let's make arrangements, let's figure this out, etc.? Was there any record?
I can't answer that question, counsel. I think it's a question that's more appropriate for the defendant.
Well, all I'm saying is the record should reflect, well, let me ask you this. If someone's more likely than not to die, your patient, do you think you should make a record of that in the chart, that you've informed the patient and or the family that they have they're not going to survive?
No, I don't, sir. When you're taking care of a critical patient, and that's one of many patients you're taking care of in the ER, your job is to document what happened, not to write a book. And I don't think that that's something that most people would take the time to enter into the record. He's busy with patient care at that point.
Well, then that brings me to my next point. So, not important to make a quick one-sentence note, patient might die, likely to die more than 50%. That's your testimony, right?
My testimony is that in 17 years of practice, I've never made that entry into the record.
But you just told us she's in bad shape.
Yes, sir.
But then you told us, but the risk of associated intubation and this and that, it's better to wait. So you're basically telling us, here's a patient who's probably going to die, but there's risk with intubation, so let's just wait. And if you just wait, that means they're more likely to die, doesn't it? If you're going to balance the two, between the risk of waiting, because maybe intubation might be difficult, where the person's likely to die, then you've actually increased the likelihood of her dying, haven't you, in this case?
Not in this case, no. Because the reason that she was more likely to die was because of refractory hypotension. Intubation would have done nothing to preserve her blood pressure. What she was in trouble with was perfusing her organs, and intubation improves oxygenation. And oxygenation was never her primary problem. Blood pressure was.
Doctor, in the first 2 hours, did anybody try retrograde intubation?
No.
Did anybody try cricoid-thyrotomy? Those, certainly with the retrograde intubation, if you use a triple lumen kit or any of that, certainly was less likely to cause any bleeding in case you were worried about an enlarged goiter, true?
Possibly.
That would have been a nice attempt to help get some oxygenation, help deal with the airway issues in this case, wouldn't it? That was certainly an option for the defendant.
It was a consideration. The success rate with retrograde intubation is not particularly high.
Well, you already said she's likely to die. So if we're balancing likely to die, or we're going to try, let's try this, why not go for it? Because she's likely to die anyway. So let's go for it.
Because she's not dying because she's hypoxic. She's dying because she's hypotensive and intubation is.
Well, she ended up dying of hypoxia. The lack of oxygen actually caused the organs to go into distress, and she ended up dying.
The reason her organs lacked oxygen is because she didn't have the blood pressure to perfuse them, not because she was not getting oxygen.
And we already knew she had all these problems because nobody could intubate her. All these people are standing around, nobody could intubate her.
Right. And when they had trouble intubating her, that collective group of experts at the bedside decided that further attempts would be more harmful than beneficial.
Well, I know we're out of time, doctor, but the end result is with all these people standing around, and we didn't do any of these techniques, and you're saying she's probably going to die anyway, she ended up dying. Isn't that true? I know we have no other time.
It's true that she ended up dying. I can't imagine it's true that people were standing around. Based on everything in the record, they were working very hard to save this patient's life. Their measures.
We're done with this witness, Your Honor.
Thank you. You can go back to your table. So we're going to have five minutes each for closing statements, and we'll start with the plaintiff.
How much time do we have, Your Honor?
You have 5 minutes, and I have a timer with an alarm on it.
Thank you.
You used up your 5 minutes. Sit down.
Thank you, ladies and gentlemen, for your time today. Appreciate it. I hope you can all hear me.
Order in the court. Thank you. The 5-minute timer will be reset.
Thank you, Your Honor. Counsel, Dr. Defendant. I'm really sorry we had to be here today. We really should. I mean, Dr. Cade has laid out for you in incredibly simple terms. In fact, the defense in this case, all their arguments prove Dr. Cade's points. They stick him with epi. Was it enough? He admitted, no, it wasn't. He could have easily, based on journals back in 2001, so I don't care about 2008, I don't care about 2012. Back in 2001, the standard of care is you can push, as we talked, up to 100 MCGs over 3 minutes. That would have made the difference. Dr. Cade has testified, he told you that. By failing to do that, by the defendant's choice, knowing that it was ineffective, it's not as if he didn't know. He admitted to you it didn't work. I had to say, that's nail one in this coffin. The second failure of the defendant is what was done to protect the airway. You know, we hear, oh, she's in bad shape, and this and that. We've named at least 3 to 4 procedures that he's eminently qualified to do. And I'm shocked, as you may be, that at no time did any of these doctors, including the defendant, who, by the way, didn't seem to want to take responsibility for his actions. I counted over 7 weeds instead of me, or I, does not want to accept responsibility for what happened, and that's why we're here. He finally did, on my cross, said, yes, I'm in charge of the attendant. He could have done these techniques. Dr. Cade testified that these techniques would have saved her life. That's Hoffman nail number 2. Nail number 3. Giving a drug, I know we can debate. There's a whole bunch of journals that you're going to get when you deliberate that talk about how you do not give a poison on top of a poison. You don't have to be an expert to know that you can have a reaction and then he decides to give her a drug. It doesn't help her. What was the point of that? Nail number 3. We're not talking the ECMO standards of today, by the way. We're talking about bring cardiovascular surgeons down into the ER to administer the techniques that Dr. Cade talked about. When everything's failing, what I'm envisioning and what the record shows is they're watching my client. They're basically dying. No one tries any of these techniques, nail 1, nail 2, nail 3. And where you go, hey, let's get her transferred so cardiovascular experts can take care of her. None of this happens until almost 3 hours later, after they admit she's an extremist and is in horrible shape. That's nail number 4. Unfortunately, instead of a transfer to a hospital where the doctors could have taken more aggressive action, which clearly was indicated when someone's in this extreme situation, she had to get transferred to a coroner. We find that we've proven our case. The evidence is solid here. We've certainly proven it by more likely than not. and we ask that you find for the plaintiff. And we do thank you for your time today.
Thank you,
Your
plaintiff.
Honor.
Thank you, plaintiff attorney. Defense attorney, closing statements, please.
Ladies and gentlemen of the jury, thank you. On behalf of my client, we thank you for your time and your attention in this matter. As I said in the very beginning, there's no dispute that this is a tragic case. Despite the tragedy, the law requires you to set aside your sympathy when you deliberate and reach your verdict. What the law does not require you to set aside is your common sense. We ask you to use your common sense and evaluate the testimony and the evidence that you've seen and heard today. And we believe that once you evaluate the testimony that you've heard today, evaluate the evidence, that you will ultimately render a verdict for the defense in this case. As you've heard, this patient was in extremis when she arrived. She was in anaphylactic shock. Every attempt that could be done was done in order to attempt to save her life. We've heard much to do about an earlier intubation, and you've seen from the evidence that an earlier intubation was not indicated. When an intubation was indicated, it was done, and it was done successfully when it was indicated. She was given medications which were appropriate, the epi, the glucagon, the pressors, the Levaquin. As you've heard, all of those were done, and all of those were appropriate. Unfortunately, as you know, not every life can be saved. The fact that this is a tragedy is not the responsibility or the result of anything that Dr. Colley did or didn't do. Thank you.